Hello and welcome. My name is Dr. Brian McClelland, author of Marketing Dentistry Kaizen Style, Small Steps to Big Profits. You can find my website at www.dental-marketing.org, where there's this article review and many other article reviews, as well as many presentations available, particularly in the education forum. Today, I would like to talk about an article that I found in the International Journal of Oral and Maxillofacial Implants, volume 26, number 6, pages 1241 to 1246. The title of the article is The Effect of Implant Abutment Modification on the Extrusion of Excess Cement at the Crown Abutment Margin for Cement-Retained Implant Restorations. Big title, but great topic. The authors are Wadawani and Pinheiro et al. Fixed implant restorations can be screw or cement retained, and the advantages of cement retained restorations include improved aesthetics, control of the occlusion, decreased cost and time, and I think most importantly there's a familiarity with the restoration and the techniques and a similarity between cement retained restorations and natural teeth. Excess cement is cited as being a major cause of peri-implantitis and is estimated to have an incidence of about 80% of all cases of peri-implantitis being as a result of excess cement and cement extrusion, with bacterial colonization of that extruded excess cement. The peri-implantitis may or may not become clinically evident for 4 months to 9.3 years. So almost up to 10 years later, you may actually develop this peri-implantitis because of extruded cement. Cementation procedures to minimize extrusion of cement include limiting the amount of cement used, which makes sense, as well as crown venting procedures. These restorations are placed on stock abutments or custom abutments, which may be either solid or hollow. It's been hypothesized that an open or hollow abutment may provide an internal reservoir for cement and minimize extrusion and therefore potential future issues. So the goal of this study was to evaluate if two vent holes placed in the actual abutment, 180 degrees apart, in the axial walls of a hollow abutment would decrease the extrusion of cement and or affect the vertical seating of a crown or coping on an abutment. So with materials and methods, a total of 27 abutments and copings were made for them and fabricated by the same technician and confirmed to seat well on abutments. These were then randomly assigned to one of 3 groups. There was a control group where the screw access hole was completely filled before cementation. In other words, no space for internal venting. An open access where they took PTFE, basically plumber's tape, placed it over the screw access hole and the screw head, but the abutment was otherwise left open and unfilled. And then they have the equivalent open access but also vented. So the same abutment, it's also hollow, it has the plumber's tape, but it has 2 vent holes that were 0.75 millimeters in diameter that were made 3 millimeters below the occlusal edge of the abutment, 180 degrees apart. Temp-on cement was the cement used during these testing procedures. And the way this was done is the copings were filled with 75% of the way up the coping and weighed before seating. The same seating pressure was used for all copings using a spring compression device. All excess cement was then removed and the weight was recorded again. With these measurements, all of the calculations were done, and the vertical height changes were also measured with a custom jig. The results. There's no statistical difference was noted in vertical seating in all 3 groups. The closed abutment group extruded 90% of all the cement placed. The open abutment group extruded 54% of its cement, and then the open abutment group that was vented extruded 36% of all cement. And these numbers are statistically significant. So the amount of cement placed in a crown before seating is at the operator's discretion, and in this study, an excess amount of cement was used to simulate the worst-case scenario. 2 vent holes did decrease the amount of cement extruded significantly. The location and the size of the vent holes in an abutment needs to be investigated further to determine the best configuration, and the vent holes in the study were in titanium abutments. And other abutment materials, such as zirconia, may not maintain their strength with these vent holes. So, in conclusion, screw-retained restorations eliminate this variable, but cannot always be used depending on many clinical variables, particularly in the aesthetic zone with the exit of the screw access hole. So thank you for tuning in for this article review. Again, my name's Dr. Brian McClelland, author of Marketing Dentistry Kaizen Style, Small Steps to Big Profits, available at Amazon and at www.dental-marketing.org. Thank you.